Hello, everyone, and welcome to today's webcast. Cannabis-based therapies, a new paradigm for wound management supported by Spectrum Therapeutics, a leading licensed producer of medical cannabis. Before we get started, I would like to go over a few items so you know how to participate in today's event. You have joined the presentation listening through your computer speaker system by default. If you would prefer to join over the telephone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation, and we will collect these and address them during the Q&A session at the end of today's presentation. Today's webinar is being recorded, and you will receive a follow-up email within 24 to 48 hours with a link to view the recording. I would now like to introduce Dr. Vincent Maida. Dr. Vincent Maida is a consultant in palliative medicine and wound management at the William Osler Health System in Toronto. He was born in Toronto and graduated with his MD from the University of Toronto. He was promoted to Associate Professor at the University of Toronto in 2011 after the minimum 5 years from his junior promotion. He completed his MSc in Wound Management at the University of Toronto in 2010. In 2011, he completed his Medical Teacher Certificate, and in 2014, he completed his Certificate in Patient Safety and Quality Improvement, both at the University of Toronto. Dr. Maida is an internationally recognized expert in cannabinoid medicine with more than 2 decades of clinical experience. Dr. Maida is an active researcher with particular interests in pain and symptom management, wound management, prognosis, and medical education. Over the past 10 years, he has published 6 medical textbook chapters, over 30 original research papers, created numerous original conceptual innovations, inventions, and patents in palliative medicine and wound management, as well as delivering over 100 national and international presentations on 5 continents, 17 countries, and over 50 cities. Over the past 10 years, his publications have been cited by other researchers and authors more than 800 times worldwide. Dr. Maida was awarded the Queen Elizabeth II Golden Jubilee Medal in 2002 and the Queen Elizabeth II Golden Jubilee Medal in 2012 for his work in palliative care and wound management, and overall contributions to Canadian society. Thank you for joining us, Dr. Maida. Over to you.
Good evening to everyone. Welcome to my webinar. I'm very honored to be given the opportunity to share my almost 3 decades of clinical experience with cannabis-based medicines with you tonight. A special thank you to both Wounds Canada and Spectrum Therapeutics for hosting and sponsoring respectively this event. Tonight, I aspire to launch a new era in wound management, one that gives our patients hope for less suffering and improved outcomes with their wounds. So without further ado, let us start. Cannabis-based medicines, a new paradigm for wound management. Acknowledgements: I was born, educated, reside, work, and conduct my research on lands that are the traditional territory of the following Canadian First Nations. Disclosures: I am part of advisory boards and speakers bureaus. I own patents and intellectual property, and I do have some stock holdings in the below mentioned companies. So let's dive into this presentation, starting off with a real case. This lovely lady, her name is Emma, and she's an 82-year-old seamstress. She has metastatic salivary cancer. She has malignant wounds from her metastases involving the left side of her lateral neck and supraclavicular fossa. When asked about her pain, she describes her baseline pain as 0 out of 10. However, whenever her visiting nurses attend her home to change the dressings, she has enormous pain that she rates at 10 out of 10, only associated with dressing changes. Her current treatment includes Percocet, 1 tablet 4 times a day, Lyrica 25 milligrams twice a day, topical lidocaine, and also topical methadone. Result-wise, she has less than the desired amount of clinically significant pain relief, namely less than 30%, but only after 60 minutes. In other words, she's suffering for up to 60 minutes with very severe pain associated with her dressing changes. Is she happy with her treatment? Well, not only is she not getting good pain control, but she also has severe symptoms, side effect symptoms in the nature of constipation, edema, and dysphoria. Emma exemplifies the typical scenario in patients with chronic wounds where they are suffering intolerably despite being given all of the current guideline medications. Tonight's presentation is all about trying to improve Emma's state and the state of all patients who have wounds in relation to pain and symptom management and other outcomes. So let's talk a little bit about the reality of chronic wounds globally. The World Health Organization has declared chronic wounds as a major global public health crisis. It affects up to 6% of the population, which means there's approximately 500 million people worldwide with chronic wounds. Curiously, females have twice the prevalence and incidence of wounds than males. The United States of America spends up to $80 billion annually on wounds. Something that has been talked about a lot in the news feeds lately is the fact that we have a couple of severe global health care trends. One is the opioid crisis, and the other is the proliferation of antibiotic superbugs. Opioids tend to be overused in wounds, and in relation to superbugs, a little known fact is that all of our current superbugs, including MRSA, etc., all were derived from the cutaneous, from the integumentary and wound scenario. So clearly we need to look very critically at what we're doing with wounds. We're clearly overusing opioids and we're clearly overusing antibiotics, and the results, we know what the results are. Outcome-wise, we still have a lot of room for improvement. Overall, chronic wounds have very poor healing rates worldwide, high recurrence rates. Worldwide, amputation rates are rising. All the while, our patients are suffering intolerably. And above all, wound pain continues to be very poorly managed. And finally, chronic wounds are leading the world in terms of healthcare expenditure, tied with dialysis at 7.5% increase per year. Wound-related pain is highly prevalent with chronic wounds. In fact, up to 65% of patients with chronic wounds will report some level of pain. Pain intensity is associated with not just the overall size of the wound, but also multiplicity of wounds. So obviously, the more wounds you have, the more pain patients will experience. Numeric rating scores of pain tend to be higher in females. Of all the different types of wounds and locations, malignant wounds and perineal and genital wounds are reported as the most painful. Wound-related pain is also associated with other disturbances such as sleep problems, reduced quality of life, and a number of emotional symptoms, including anxiety, depression, fear, and anger. When looking at wound-related pain, it's not just within the wound beds, but also within the peri-wound tissues. And the causes of pains pathophysiologically include processes such as necrosis, ischemia, infection, and inflammation. Chronic pain is also driven by a number of pathophysiologic processes, including sensitization peripherally and centrally, NMDA activation, hyperalgesia, allodynia, and neuroplasticity. So chronic wounds produce chronic pain, and chronic pain is essentially more of a disease state in itself, not just a symptom. It's important to distinguish the different types of wound-related pain. I'm going to divide it in binary fashion into baseline pain and breakthrough pain. So baseline pain, also referred to as background pain, can also be defined as the average intensity of pain experienced for 12 hours or more in a 24-hour period. Breakthrough pain are transitory episodes of intensified pain that occur upon a background of stable pain. Breakthrough pain is probably at the heart of our overall problem with pain management. And studies have shown that when patients do experience a significant amount of breakthrough pain, they tend to report their overall level of pain control as poor. Patients with breakthrough pain have also been shown to have higher levels of baseline pain, peak pain, depression, anxiety, and functional impairment. And not surprisingly, breakthrough pain has a significant negative effect on a person's overall quality of life. Breakthrough pain patients also are associated with increased healthcare costs. So let's look at perhaps an oversimplified classification of breakthrough pain. There's three types of breakthrough pain. One is end of dose failure, which, by the way, some researchers tend to debate whether it should be included as a breakthrough pain, but let's just, for the time being, regard it as such. The main types of breakthrough pain are idiopathic or spontaneous pain and incident pain. And incident pain may be either volitional or non-volitional. Volitional meaning associated with an event, such as a dressing change, a debridement, a biopsy, a washing of a wound, etc. And non-volitional means something that just occurs, again, without with an event, but it's not an event that is initiated by anyone in particular. It could be a pain that's initiated by a sneeze, a cough, a spasm of some sort. So let's look at end of dose failure. This animated image shows kind of a sine wave. And if you look at the x-axis, you can see that the two peaks are at approximately 12 hours apart. And this patient likely was taking a medication that has about 4 to 6 hours of pain relief. And because they were taking it every 12 hours, they get this peak and trough. So end of dose failure just means that perhaps they need to take that particular analgesic a little more often so that peak and trough effect is eliminated. Idiopathic or spontaneous pain exhibits this type of pattern. So upon this baseline level of approximately 2 out of 10 pain, you get these sudden severe spikes just out of the blue with no event associated with it or preceding it. This is most in keeping with a neuropathic type pain, a primary neuropathic pain. Incident pain, both volitional and non-volitional, exhibits this pattern. So baseline pain, and then you have an incident, whether it's a dressing change, in the case of a volitional event. Another volitional event could be, as I said, a biopsy, a cleansing, a debridement, etc. Or it could be a non-volitional event, like I said earlier, in the form of a cough, a sneeze, etc. Our current paradigm for treating wound-related pain is largely centered around using opioids and nonsteroidals, gabapentinoids, SSRIs, SNRIs, TCAs, the like. Clearly, this paradigm is not serving our patients properly and it is leading to an excessive use of opioids, which we all know the results of. Wound-related pain also directly in itself inhibits wound healing. It has been said by many theorists that pain itself is catabolic to the body. In other words, it creates a chemical milieu in the body that inhibits wound healing. But not only that, wound pain itself leads to vasoconstriction. When a person is having pain, one's arteries, both large and small, go into a state of constriction. And as such, less blood is being delivered to areas that are involved with wounds, and thus wound healing becomes less likely. It's been estimated that more than 70% of patients with chronic wounds use opioids. Our current paradigm for treating pain is highly problematic. All of the major classes that we are employing cause severe problems. The opioids, tolerance, constipation, nausea, vomiting, etc. Non-steroidals are associated with GI bleeds, renal failure, etc. And by the way, opioids and non-steroidals are the leading cause of iatrogenic deaths on a global basis. Gabapentinoids cause edema and dysphoria. TCAs are associated with significant burden from an anticholinergic standpoint. SSRIs and SNRIs are associated with nausea, vomiting. acetaminophen, hepatic and renal impairment. And lidocaine, interestingly, I saw the front page of the Toronto Star last week. There was a report about a publication in the New England Journal of Medicine just last week where a person developed methemoglobinemia from using topical lidocaine. This is a very rare complication. It's called the blue man syndrome. But nonetheless, it is theoretically possible that some people develop this idiosyncratic reaction. And lastly, our current guidelines do not address breakthrough pain. They mostly address just the baseline pain. So I mentioned opioids. I firmly believe that we're overusing opioids in relation to wounds in general. And here's a new a recent study that shows that opioids directly inhibit wound healing. And furthermore, the wound inhibiting factor of opioids increases with dose. So the more opioid you use, the more inhibition of wound healing that you're going to see. Non-steroidals too inhibit wound healing. Non-steroidals inhibit production of prostaglandin E2 and thus reduce pain. So there's no question that non-steroidals can reduce pain through that mechanism. But also non-steroidals inhibit healing by reducing nitric oxide levels and also by direct antiproliferative effects on both fibroblasts as well as angiogenic tissues. Non-steroidals also inhibit epithelial differentiation. And by virtue of inhibiting prostaglandin E2, there's an association to increase scarring when using non-steroidals. The new paradigm that I want to introduce this evening is one where we're looking at a novel approach that involves cannabis-based therapies, where we're using THC, CBD, other cannabinoids, and non-cannabinoids. So in essence, this is what I'm trying to impart on you tonight, is combining cannabinoids on many different levels. We could be using the vaporized cannabis flower to treat breakthrough pain. We can use orally ingested cannabis extracts, such as the oils that are marketed by the various licensed producers in Canada for more baseline pain, and topical cannabis-based medicines to treat both baseline pain and also breakthrough pain. So ultimately, a combination of all three different delivery systems to achieve not just improvements in wound-related pain, but also other wound-related outcomes such as wound healing. So let's introduce cannabis-based therapies. Cannabis-based therapies, it's a hugely hot topic worldwide. This is some data that shows the number of publications from PubMed on cannabis-based medicines in general, and you can see it's growing at an exponential rate. Moreover, cannabis is sweeping the world. More and more countries are embracing cannabis as an option, as a therapeutic option, a viable one, and practically every week or two there's a new country that has legalized it medically. Let's digress with a bit of history. Cannabis has been used worldwide for thousands of years, probably 7,000 to 10,000 years. Ancient cultures have used it for a variety of medical maladies such as pain, spasms, etc. It's also extracts from cannabis and byproducts of the cannabis plant have been used also for food and for fiber. So when my naysayer colleagues wonder about evidence base, I remind them that probably the biggest testament to evidence base are treatments that have stood the test of time. And clearly cannabis having been used for thousands of years, that is truly the test of time. At the turn of the last century, there was a lot of activity in relation to research and clinical use. And then something happened in 1936. The U.S. government, in tandem with a couple of corporations, I believe they were the DuPont Corporation and Randolph Hearst Corporation, which were involved in pulp and paper production, began to see that their market share was dropping because cannabis paper derived from cannabis fiber was leading the world. And fearing losing market share, they teamed up to make this propaganda movie called Reefer Madness. Well, the bottom line is it worked really, really well. And basically it drove cannabis and cannabinoid science into the dark ages. We emerged from the dark ages with what I would call the cannabis renaissance, which was started off by Professor Raphael Mechoulam in 1964 at the University of Jerusalem. He began to explore the various molecules from the cannabis plant, and he was the first to discover the chemical nature of THC. It was one of his graduate students, actually the late William Devane in 1990, he discovered the cannabinoid receptors. And in 2011, another icon in the cannabis world, Ethan Russo, postulated, among other things, the entourage effect, the ability of multiple different molecules from the cannabis plant working synergistically to improve clinical outcomes. So we're truly in a time of renaissance, and we have exciting times ahead in terms of developing clinical utility for this class of therapeutics. So Canada has been a leader in terms of cannabis regulations and legalization. And in 2001, Health Canada came out with the MMARs. And through a series of lawsuits and pivotal Supreme Court rulings, the whole regulatory framework in Canada has evolved accordingly. One of the most significant moments was in 2015 when Owen Smith versus Canada, the Supreme Court of Canada ruled in favor of Owen Smith. And as a result of that ruling, the definition of medical cannabis was expanded to go beyond just dry cannabis flower that could be smoked or vaporized, and thus began the era of extracts and oils and edibles and topicals, etc. The current regulatory framework is now called the ACMPR, Access to Cannabis for Medical Purposes Regulations in 2016. So that governs medical cannabis. And of course, in 2018, in October, the Canadian government legalized recreational cannabis. So how do patients in Canada obtain medical cannabis? Well, they should be going to their physician or nurse practitioners. And of course, if physicians or nurse practitioners aren't up to speed in terms of their education around medical cannabis, from coast to coast, there are a number of specialty cannabis clinics that patients can be referred to. It's essential that either the nurse practitioner or physician completes a medical document. It's like a prescription, but it's not a prescription. A prescription can only be given for something that has a drug information number, a so-called DIN. Medical cannabis doesn't have a DIN because it's a botanical product. Eventually, in time, when cannabis-based medicines become more widespread and licensed and so on, then at that point, we nurse practitioners and physicians will be writing actual prescriptions. But for now, we're writing medical documents, which is an authorization, not an actual prescription. And the healthcare professional then faxes or mails or electronically transmits the medical document to the licensed producer of the patient's choice. And there's over 100 such licensed producers of medical cannabis in Canada as we speak. And then the patient themselves registers with the licensed producer of their choice. And then when both have been received by the licensed producer, the patient is in a position to actually order online and pay for it and get it shipped directly to their home with some sort of secure courier. So there are, as I said, a number of expert clinics. So if a patient's family doctor or nurse practitioner is not completely confident or understanding of the process, then they can always make the referral directly to a number of different clinics across the country. This is what the Health Canada medical document looks like. And it's very simple. It just asks for some demographics, some parameters on the amount of THC that they can access, and a time limit of up to 12 months. This is probably one of the most important slides of my entire presentation on this slide, because it's important to understand the difference between recreational cannabis and medical cannabis. They both involve cannabis, but it's a different intent. Patients who seek recreational cannabis do so because they're looking for a state of high. They're looking for that psychotomimetic reaction that they call a high or euphoria. And this derives from THC. So patients who are looking for recreational cannabis want as much THC as possible because it'll give them the greatest level of high. This is in contradistinction to medical cannabis. Medical cannabis, patients who seek medical cannabis are seeking it to obtain positive healthcare results. And generally, medical cannabis strains are higher in CBD in general relative to THC. Both recreational cannabis and medical cannabis in Canada can be accessed through legal and illegal routes. So somebody can purchase recreational cannabis both legally and through legal and licensed methods through, for instance, in Ontario, the Ontario Cannabis Store, or from some of the storefront operations that have been official. But also people can obtain it illegally through non-licensed organizations such as illicit markets, the underworld, the illegal dispensaries that are very prevalent, especially in the city of Toronto. So it's important to note that, and medical cannabis too can be obtained through illegal and non-licensed sources like dispensaries, and even on Amazon.com, patients are obtaining illegal, non-licensed medical cannabis. So we need to emphasize to our patients that the only way to get it legally and licensed is through the method that I've earlier outlined, where somebody licenses with one of the licensed producers in Canada, of which there are over 100. So medical cannabis, and that's the focus of tonight. We're not talking recreational cannabis tonight. We're talking medical cannabis, can only be obtained through legal and should only be accessed through legal and licensed routes. Let's talk about the scientific foundation, because this is really what excites me a lot and also validates everything that we're talking about this evening. And it all relates to the endocannabinoid system. The endocannabinoid system is the reason why medical cannabis works, because medical cannabis interacts with the endocannabinoid system. Bit of a historic backdrop. The endocannabinoid system is only one of two chemical signaling systems that has survived over 500 million years of evolution. Doesn't that tell you something? That tells you that clearly that cannabinoids have an incredible role to play in interacting with the endocannabinoid system. The endocannabinoid system is ubiquitous. In fact, it's the most ubiquitous chemical signaling system in the world, in the human body. It's represented in all of the organ systems in our bodies, from head to toe. And guess what? The integumentary system, since it's the biggest organ and also the heaviest organ, it stands to reason that it has an incredible footprint in the integumentary system. So the endocannabinoid system, our knowledge around the endocannabinoid system has been growing exponentially. 20 years ago, we only spoke about the classical human cannabinoid receptors, namely CB1 and CB2. And even CB1 and CB2, there's 10 times more CB1 and CB2 receptors in our bodies than opioid receptors. And unlike any other chemical signaling system, endocannabinoid receptors are both binding extracellularly and intracellularly. The ligands that bind CB1 and CB2 are AEA, or anandamide, or N-arachidonyl ethanolamide. That generally binds CB1, while 2-arachidonyl glycerol binds CB2. And there's also biosynthetic and degradation pathways for both anandamide and 2-AG. The integumentary system has elements of the endocannabinoid system in all levels, not just in all levels, but all appendages. So the hair follicles, the nerve fibers, the arterioles, the venules, the sweat glands, etc., all have representation of endocannabinoid elements. And thus, it's obvious that there's enormous potential to manipulate and modulate the endocannabinoid system in the integument, both cutaneous membranes and mucous membranes, to achieve positive clinical outcomes. This is a recent paper. So, 20 years ago, we only spoke about CB1 and CB2. You can see that this is a recent paper published just a few months ago showing just how much our knowledge around the endocannabinoid system has grown. And it's going to continue to grow. So even on the receptor level, we're no longer talking just CB1, CB2, but cannabinoids can also interact with the TRP, the ionotropic TRP family of receptors, the GPR receptors, the PPAR, the nuclear receptors inside cells. And this is probably at the root of the potential for cannabinoids to exert epigenetic pathways and mechanisms. But also non-classically cannabinoid targets like 5-HT, glycine, alpha-adrenergic 5-HT, and also NMDA. The authors of this paper forgot to mention NMDA. Both THC and CBD are able to antagonize NMDA, which is at the heart of chronic pain. And of course, there's enzymes, membrane transporters, etc. And stay tuned, folks. We're going to see further evolution in our understanding of the endocannabinoid system. And with that, with our advancing understanding of the endocannabinoid system, will come about more opportunities to use cannabinoids to treat so many more different medical maladies. A number of people, including Ethan Russo, have postulated and theorized that integumentary and wound conditions may simply be a state of dysregulation in the endocannabinoid system. So by either decreasing endocannabinoid tone or increasing endocannabinoid tone, we can be treating a number of different maladies. So let's talk about cannabinoids. And 20 years ago or so, when we spoke about cannabinoids, cannabinoid meant basically THC and CBD, because they were the only things that were thought to bind the classic endocannabinoid receptors. We now know that non-cannabinoids also have some sort of interaction, either directly or indirectly, with elements of the cannabinoid system. But let's just, for the sake of simplicity, look at three sources of cannabinoids. One is the botanical one, and that comes from the cannabis plant. And there's over 80 different cannabinoids. The most plentiful and clinically relevant as of 2019 remain THC and CBD, but researchers worldwide are exploring the potential for other cannabinoids in terms of their clinical utility. And cannabis also yields more than 350 non-cannabinoids that include a number of terpenes and terpenoids and flavonoids. I mentioned the endocannabinoid system, so the inner pot system, if you will. The two main agonists are anandamide and 2-arachidonylglycerol. And then there's also synthetic pharmaceuticals. In Canada, at one point we had both Sesamet and Marinol, which are essentially facsimiles of THC. And pharmaceutical-wise, we also have access to Sativex, which we call it a pharmaceutical, but technically the THC and CBD is derived from a plant source, but it's made into a pharmaceutical called Sativex, which is a spray, a one-to-one spray of THC and CBD that's sprayed onto one's tongue and buccal cavity. So let's look critically at this slide. This is an important slide as well. This shows the different routes of administration. And just reflect on some of my earlier slides around breakthrough pain and baseline pain. You can see that, for instance, patients who have breakthrough pain are going to respond well to either smoked cannabis or vaporized cannabis, because both smoked and vaporized gives you an onset of action of 5 minutes. So can you imagine our patient Emma at the beginning of my presentation? She could have vaporized, for instance, some vaporized or smoked some medical cannabis 5 minutes or 15 minutes, 5 to 10 minutes before the visiting nurse came, and she might have been able to avoid the horrific breakthrough pain, incident breakthrough pain that she experienced. The duration of either smoked or vaporized is 2 to 4 hours. The oral route, whether it's the oils or in the form of brownies and other baked goods or teas, the onset of action is much slower and less predictable. It's between, onset of action is 30 to 60 minutes, but it can last up to 12 hours. And below are the pharmaceuticals, the nabilone, which starts to work 60 to 90 minutes and is also up to 8 to 12 hours. The key point to consider in this slide is that both smoked and vaporized are more amenable to patients' self-titration. So thinking of that patient with a lot of breakthrough pain, whether it's spontaneous or related to incidents, the ability to self-titrate with vaporization or smoked is a huge asset to the patient. So let's look at individually the different ways that medical cannabis can be utilized. Smoking is the classic way of using medical cannabis, but of course, as healthcare professionals, we have an obligation to discourage smoking because of all of the other collateral damage that it can produce, both to the patient and to patients' family members or anybody else in their environment. But when you think back to my case of Emma, Emma has terminal cancer. She doesn't have any small kids at home. She's not very dexterous, so using a vaporizer might be very difficult for her to use. And she has a life expectancy of less than 6 months. Frankly, she wouldn't be doing herself any harm if she smoked. So we always have to look at cases. We shouldn't automatically discount smoking medical cannabis, for the reasons that we mentioned. We need to look at it in an individual, on a case-by-case basis. But obviously, overall, we should be discouraging smoking for the collateral reasons that we mentioned. But nonetheless, it's, as you saw from the previous slide, very rapid absorption, very rapid onset of action, and easy to titrate. Vaporization is the favored manner of delivering short-acting effects. And in vaporization, you're not combusting the medical cannabis. When you smoke it, you combust it, you burn it completely, you convert it to ash because you're exposing the cannabis to up to 1,500 degrees Fahrenheit through burning it. In vaporization, we're not burning the material. We are simply heating it up, cooking it up, so to speak, so that the vapor that results is able to be inhaled. Now, this is the only safe way to deliver vaporized cannabis. It's the so-called volcano vaporizer, and it's the only one that's approved by Health Canada as a Class 2 medical device. Now, I'm sure many of you have heard that the world is in the midst of a vape crisis. There's been some mysterious deaths, especially in the United States, and they've been linked with a portable device made by one particular manufacturer. And there's been an active investigation going on in terms of why these patients have developed the respiratory failure syndromes that they have. And it's thought that there must be some sort of impurity through the technology of the portable vaporizing units, plus the fact that the companies that have marketed the aforementioned devices may be selling their own cartridges, which may contain impurities, etc. And also, some patients have actually been using oils as vaporizing media, and that's not to be recommended. Vaporization is intended to be using dry cannabis flower only. So I stand to be corrected, but as of now, there have been no misadventures or complications associated with the volcano unit when they're using licensed legal medical cannabis. Now, a patient may also have a Class 2 medical device like the volcano and be using illicit cannabis, and then basically who knows what they're actually delivering to themselves. So just to summarize, we should be using for vaporization only the volcano, which is registered. And by the way, patients, because it's a Class 2 medical device, can also get the cost of the vaporizer deducted on their income tax return. There's also oral delivery in the form of cooked or baked goods. Again, much slower onset, as you recall from the previous slide. And peak levels are very unpredictable because it's also linked with absorption capacity. Certain patients absorb quicker, some slower, and it's a longer duration of effect, perhaps up to 12 hours. But my main concern with cooked and baked delivery is how much is the patient actually getting? Imagine if a patient takes just a bite out of this brownie. We have no idea how much that patient is getting. So, in terms of knowing, being precise in terms of how much drug the patient is getting, it's hit and miss, and we don't have any objectivity linked to it. Oils have become very popular, and I like oils because at least you can have a handle on the number of milligrams that the patient is actually getting. So the licensed producers, and I always emphasize licensed legal producers of medical cannabis, they quote on their materials how many milligrams of THC and CBD are present in every milliliter of oil. So healthcare professionals can actually counsel their patients to start with certain amounts. So for instance, if a particular oil has, say, 20 milligrams of CBD per milliliter, and if the healthcare professional tells the patient to take a half a milliliter, that means they're getting 10 milligrams of, say, CBD. So it's easy to keep track of the amounts taken and so on. So you can titrate accordingly. In relation to teas, there's a very low bioavailability of cannabinoids in tea because tea is largely an aqueous medium. So it's not, the bioavailability is very low because of the aqueous medium. The new kid on the block is the topical application onto integument, and this is something that I've been working on and researching over the past decade or so. We don't have a lot of data at the moment in terms of pharmacokinetics and pharmacodynamics. One has to recognize that absorption through intact integument is very minimal because essentially intact integument is very impervious. And the only way for active agents to get into the body are through the sweat pores or through the hair follicles themselves. Of course, there is some level of diffusion, but it's minimal. This is in contradistinction to a wound, which is a breach in the integument. And a wound is also a lipophilic base, unlike external skin, which is relatively hydrophilic. So let's talk a little about medical cannabis dosing. There are no clear dosing studies in existence yet. But in general, if one is using either a vaporizer bowl or an average size joint, unlike what Cheech in our image is showing, that's probably a quarter pounder, but an average sized cannabis cigarette or an average vaporizer bowl takes on about 0.5 to 0.75 grams of dry cannabis flower. My advice to patients, always start low, go slow, stay low, and be patient. Patients who request medical cannabis usually are long-standing suffering patients. And of course, the expectation is that, they take their first vaporizer bowl and they're instantly better. Well, it does take time to especially wind down chronic pain. Chronic pain is more of a disease, and as such, that disease, because it involves neuroplasticity and other pathophysiologic processes, does take some time to wind down. So we always need to emphasize to patients to be patient, and in order to avoid side effects and other issues, we always recommend to start low and go slow. It's also important to elicit a good history of the patient. I always ask my patients about their history in relation to recreational cannabis, pre-legalization. Did they ever try a cannabis joint during their youth or whatever, or at parties? And what did it do to them? And you can gauge from that simple question or series of questions whether they're going to be tolerant or okay with taking THC or not. You see, THC is what generally has all of the side effects, carries most of the side effects. CBD is relatively innocuous. So in patients who are completely naive, we have no idea what THC can do to them. I always start off with CBD alone. And this is an approach that has kept me in good stead in terms of avoiding serious side effects, especially psychotomimetica side effects that may occur in a THC naive patient. Again, I always start low and go slow. I'll start off, say, with oils and give the equivalence of 10 milligrams QHS for 3 to 5 days, and then I step up to BID for 3 to 5 days, and then TID. And then I can double the CBD to 20 milligrams TID for 3 to 5 days and onwards. And then depending on their symptoms and their history and their tolerance, I'll slowly start to introduce THC, because recognizing that both THC and CBD have both robust analgesic capacity. And the initial dose of THC in my practice, I generally will start with no more than 2.5 to 5 milligrams at QHS, and then build on that. It's going to be different for different patients. It's not going to be, the use of cannabinoids among patients is the most individualized form of healthcare, because it's not going to be so dogmatic as is treating hypertension or other medical conditions. Many of you will worry about the interactions with other medications, and what I recommend to all of my colleagues who inquire about potential drug side effects is develop a good relationship with your pharmacist. And whenever I have a tough case of patients with many different drugs, I always pick up the phone and reach out to one of my pharmacist colleagues, because they have access to databases and knowledge that even most physicians aren't accessible to. This is a very busy slide, but really the only concern here is that THC, CBD, and vaporized cannabis has a small degree of CYP3A4 inhibition. And I mention this because 3A4 is the busiest hepatic isoform in terms of metabolizing drugs, common medical drugs. So just beware of that. If a person's on a high dose of THC and CBD, then that might be clinically relevant. And the only other concern is if the patient is already on other CYP3A4 inhibitors like clarithromycin, ketoconazole, HIV antivirals, aprepitant, or even grapefruit juice, you can get an additive effect. So it's always important to take a very good history in advance of one's clinical examination. So in terms of contraindications and precautions, this slide perhaps is a little outdated, but it says under 25, and that's in relation to THC alone, because for instance, a young man's brain reaches maturity at about age 25, and there are some studies, both preclinical and human, that show that THC, high doses of THC, might affect brain development. So as long as we're not overusing THC, we could probably use it in younger populations, but do beware that we should be minimizing our use of THC under age 25. Of course, pregnancy and lactation, that goes without saying. Schizophrenia and psychosis. If they've had a psychosis with recreational illicit cannabis in the past, you might be a little cautious in giving them medical cannabis. But as long as you're titrating it slowly and keeping it at a low level, you may not have any side effects. And furthermore, I know this is something that's been debated, but generally speaking, when you give CBD concurrently with THC, it tends to negate a lot of the negative side effects of THC. Compromised cardiac status is a concern with THC. THC has a tendency to lower one's blood pressure because it vasodilates. So patients may step down their blood pressure by about 10 millimeters of mercury, and as a result, they might actually develop reflex tachycardia. So do beware. Always check people's blood pressure and pulse before putting them on THC, and so on. So side effects, most of these side effects are exclusively THC-related side effects. Essentially, CBD is, as I said, a very inert and innocuous drug, but THC has the propensity to cause sedation, somnolence, dizziness in those predisposed, if it's at a high dose and rapidly administered, like smoking, etc. You may experience some psychotomimetic effects. I mentioned earlier about the vasodilatory capacity of THC. That's why patients on THC develop red eyes, because of vasodilation in the conjunctiva. Also, dry mouth is also associated with THC. The good news, however, is that a lot of these side effects are very early and transient, and as time passes, they tend to abate. Let's dive into pain management. So how does THC produce analgesia? So this is an image, a zoomed up vision of the happenings in a dorsal root horn in the spinal cord. The top orange colored neuron is a first order neuron that's delivering a pain message from the periphery, perhaps a paper cut. So as that neural stimulation comes down towards the spinal cord, it leads to the release of glutamate, which is an excitatory neurochemical that's already pre-made in vacuoles waiting for stimulation at the presynaptic site. The glutamate is released presynaptically. It diffuses to the postsynaptic second order neuron, where it causes depolarization and the immediate production of endocannabinoids. The endocannabinoids then are released from the postsynaptic surface and trek retrograde towards the CB1 receptors, which are sitting on the presynaptic neuron. And through a series of neural processes, there's an overall negation of further glutamate release. And in this fashion, through this retrograde path, this is generally and most significantly how THC generates pain relief. But this is only one of the mechanisms. There are many other mechanisms because cannabinoids don't just act at CB1, they act at a whole bunch of other receptors, as demonstrated by this very busy slide. I mentioned the TRIP system, the COX system. There's some early results showing that cannabinoids can also, exogenous cannabinoids, either botanically sourced or pharmaceutically sourced, can actually act in some way on opioid receptors, on 5-HT receptors, the PPARs, etc. So again, for those naysayers who are always thumping their fists about evidence base, well, frankly, we have evidence base. There's a significant number of randomized control studies in a variety of painful conditions showing that pharmaceutical cannabinoids relieve pain. And there's a number of randomized control studies using smoked cannabis showing improved pain. And furthermore, the most up-to-date meta-analysis and systemic review was by the very prestigious National Academies of Science, Engineering, and Medicine, led by a very prestigious name by the name of Professor Abrams from California, who led this meta-analysis, and the results of which concluded that there is, in fact, conclusive and substantial evidence that cannabis-based medicines are effective for pain, chemotherapy-induced nausea, vomiting, and MS spasticity. So then let's move on to topical cannabis-based medicines. This is my own research looking at a very severe and painful wound condition called pyoderma gangrenosum. And these patients were all on a lot of opioid, and they were still suffering in pain. And the application of cannabis-based medicines to both the wound and peri-wound area led to significant relief of their pain, as well as sparing opioids. Another case that I published was a malignant wound, a young man with a terrible, it was actually an intraoral cancer which spread to his cheek through metastatic means. And he was having severe pain, and he was using cannabis oils on the wound, both exteriorly and interiorly, intraorally that is. And not only did he achieve significant pain response, a pain relief response, He also demonstrated a 5% reduction in the tumor mass during the month that he used it topically. This paper looks at epidermolysis bullosa, which is a severe dermatologic condition affecting children. And in this small series of cases, all 3 cases were administered topical CBD by their parents, and all 3 cases reported significant pain relief, reduced pruritus, reduced blistering, and wound healing. And one of the 3 cases was actually entirely weaned off opioids, which is a wonderful outcome in itself. Topical cannabis-based medicines have also been used for herpes zoster in this small open-label trial from Germany. They used endocannabinoids that were synthesized and put in a cream form and applied to the active herpes zoster lesions, and it led to reduction of overall pain and also significantly a reduced rate of post-herpetic neuralgia, which is also a huge problem worldwide. In 5 out of the 8 patients that used this topical endocannabinoid cream reported almost 90% mean pain reduction, which is very significant, and no adverse effects. So let's transition into the final phase of my talk, and that's wound healing, and this relates to my own personal research. Normal wound healing generally follows a very ordered sequence of events that starts with hemostasis, followed by inflammation, followed by granulation and angiogenesis, followed by epithelialization, and ultimately tissue maturing and remodeling. When a wound is not healing, it's been touted and theorized that the wound itself is stuck in a state of prolonged inflammation, and hence the wound cannot progress down the subsequent stages. It's much akin to a computer that's frozen with that ominous blue screen. And we are theorizing that if we're able to reboot the wound, just like pushing the reboot button on your computer, we're able to get that patient back on track towards healing. And theoretically, it makes a lot of sense because both THC and CBD, just to name a couple, have significant anti-inflammatory properties. This further slide shows both THC and CBD have significant anti-inflammatory capacity through a number of different mechanisms pathologically. So my phase 1 trial, it's an open label trial looking at topical cannabis-based medicines for wound healing. It employs a proprietary and patented mixture of cannabinoids and non-cannabinoids. The materials are applied not only to the wound bed, wound edges, but also the peri-wound tissues. So through my work, I'm basically challenging our current paradigm in wound management, and that's the wound bed preparation module, which really doesn't address the peri-wound. And it's significant to improve the state of the peri-wound because if you're able to improve the health and integrity of the peri-wound, the wound itself is able to heal in much greater fashion. So we set the bar very high in this study. We used the worst of the worst, recalcitrant wounds with over 6-month duration. And not only were they recalcitrant wounds, but they tended to be occurring in the sickest patients. So in other words, the study looks at complex wounds in complex patients, so the ones who are most unlikely to heal. We continued with all of the previously used evidence-based and local best practices, of course, consent and exclusions. And let's look at a few cases. Our first case is Ines. She's a very sick elderly woman with a number of medical comorbidities, and she's had a particular wound since 2013. And she saw practically every specialist, dermatologist, and plastic surgeon in the city of Toronto. And before she saw me, 2 surgeons told her that she needed an amputation. She agreed to treatment with our proprietary mixtures, and this is what Ines looked like on day 1. Within a week, Ines was already improved, and within 7 months, she healed completely. Let's look at another case, Angela. Again, an elderly, ill woman with a very rare condition, but a very painful one called non-uremic calciphylaxis. And for those trivia buffs among you, non-uremic calciphylaxis has a worse 12-month mortality than most cancers. In other words, out of every 100 non-uremic calciphylaxis patients that are diagnosed at any given time, anywhere from 52 to 80%, 82% of them will die within 12 months. We proved it with biopsies. She was entered into the trial, and that's what she looked like. And within 2 months, just over 2 months, she healed completely. And her pain dissipated very rapidly with the use of topical cannabis. In fact, the initial applications in all of the previous cases, within 5 minutes, they already started to have significant pain relief, and not to mention the fact that they ultimately healed. Let's look at Ella. Ella was in palliative care. She was actively dying. So should dying patients heal wounds? Well, they really shouldn't. This lady had a whole raft of problems: metastatic cancer, systemic vasculitis. She was on medications that inhibit wound healing like azathioprine, prednisone. She had heart failure, kidney failure, recurrent DVTs. She had no business healing. She had this particular wound from an operation, and her surgeon referred her to me. And she was describing 10 out of 10 pain, both on a breakthrough basis and also on a baseline basis. That's what she looked like. 3 months later, she was entirely healed. The sad part of the story is that 3 days after she healed, she actually succumbed to her other diseases. Here's a time-lapse photography showing the progression in Ella's wound. And you can see that over time, the wound gets smaller, and you can see islands of epithelialization starting to coalesce. So this is quite remarkable. And by the way, this was biopsied and demonstrated features to suggest pyoderma gangrenosa and vasculitic components. So essentially a non-healable wound in a dying patient also healed. And not to mention, and also we shouldn't disregard the fact that she also achieved pain relief along the way. So my preliminary results, which are in the process of being published, 30 patients, very elderly, very sick, high levels of comorbid illness, diagnoses, the worst of the worst, inflammatory, vasculitic, etc., and more than 6 months duration. We even had a patient who had a wound for up to 12 years who was healing. 90% success rate, pain relief, over 30% pain relief within 7 days, no adverse events, reduced utilization of antibiotics, opioid sparing. So I've come to the end of my presentation. I'd like to recommend a couple of references for your review. This is one paper that, the one on the left is a paper that I published with a dear friend of mine from Manitoba, Dr. Paul Denick. And then the one to the right is also a Canadian paper by Carolyn McCallum from British Columbia. By reading those two papers, it'll reinforce a lot of the material that I've covered tonight. So let's close. We started with a case. Let's end with a case. This is Renata. She's a 69-year-old chef. Again, relatively young, but very sick. She has rheumatoid arthritis. She had this terrible wound directly over her Achilles tendon. She had enormous pain. We biopsied her, and she too had non-uremic calciphylaxis. Her pain, both baseline pain and breakthrough pain, 10 out of 10. She was in agonizing pain. Her previous analgesic regimen included hydromorphone, but Renata was slowly dying. She began to decline over 6 months. She became completely bedbound. She required urgent admission to hospital because basically she couldn't go on. You know, her heart was failing. She was basically not going to live a long time. So she agreed to a new analgesic regimen. We gave her CBD oil, 20 milligrams TID. We gave her THC, 10 milligrams at bedtime. And we applied the cannabis-based medicines to not only her wound bed and peri-wound associated with daily dressing changes. She also used vaporized cannabis flower 15 minutes before dressing changes and PRN. Not surprisingly, we noticed opioid sparing. She rapidly improved and became fully healed within 8 weeks. And she currently is completely pain-free, fully functional. She's regained her life. So in summary, I believe that cannabis-based medicines are one of the most promising areas of therapeutics at the moment in our world. We all have a lot of work to do. We need to improve on the current status quo in wound management. We cannot just continue with the current dogmas and paradigms. We need to look beyond those. Cannabis-based medicines are safe, effective, relatively inexpensive, versatile, and very safe. And even in terms of risk prevention models, we should be looking towards cannabis because it's much safer than opioids and non-steroidals. And cannabis-based medicines are not just effective for pain and symptom management of wounds, but also are showing promise in terms of modulating integumentary diseases and wound healing. So thank you very much for your attention. At this point, we will entertain comments and questions.
Great. Thank you so very much, Dr. Maida, for a really fascinating presentation. So we do have some questions for you, but before we do that, just as a quick reminder, there is still time. If you do have any questions, please be sure to type them into the questions pane of your control panel. All right, our first question is, what is the other system beside endocannabinoid system that has survived a long time?
I did mention it was the opioid system, the endogenous opioid system.
Great. Thank you, Dr. Maida. And the next question, this is something you touched on as well during your presentation. And the question is, can you comment on the recent cases and restriction on smoking cannabis and e-cigarettes?
Okay, well, smoking is different than e-cigarettes. E-cigarettes are a type of vaporization system. So as I said before, smoking is actual combustion of the cannabis material, and it converts it to ash because it's exposed to extreme temperatures. E-cigarettes are a variation of the vaporization technology where material is heated up, and then the individual breathes in the resultant vapors. The problem with e-cigarettes is that, generally speaking, the manufacturers of the technology equip them with cartridges that they pre-make, and we're not really aware of what they include in terms of preservatives and flavoring agents, etc. So what is happening probably, and what's prompted the concern worldwide around these respiratory misadventures, is that there could be some toxic materials being emitted through the heating process of the pre-prepared materials that are being used in e-cigarettes, and also the portable vaporizing devices. So that is why at the moment the only safe way and sanctioned way to vaporize is by using the Volcano vaporizer. That currently is the only one that's approved by Health Canada. It has an official status as a Class 2 medical device. And further,
Perfect.
even if you use the Volcano, we should only be using dry cannabis flowers that come from licensed producers. We should not be using oils in the vaporizer. We should not be using cannabis that's accessed through illegal routes. And furthermore, even though recreational cannabis is available to us in Canada, it's not really advised that patients go on their own and get their recreational cannabis and then use their vaporizers or et cetera, because they're not receiving counseling from healthcare professionals. And generally speaking, as one of my previous slides shows, recreational cannabis tends to be higher in THC. And THC, when used without healthcare supervision, can cause problems.
Great. Thank you, Dr. Maida. Okay, so our next question is, Dr. Maida, what are your thoughts on using TCBM for burns/grafts?
Yes, so I'm excited. I don't have any data, but again, as I mentioned, my phase 1 trial treated the worst of the worst. So by interpolation, I have to say that I have great confidence that it's going to be a, a slam dunk in terms of helping patients with burns, abrasions, and even multiple wounds like, say, war wounds, patients with a large part of their body affected with wounds, burns, etc., and applying to a large area of the body. I am very confident because it's the same mechanisms as with a chronic wound. So I'm really enthusiastic, and I look forward to furthering our research efforts in looking at more common wounds. The reason why I chose what I chose was I wanted to give my innovations and inventions the ultimate acid test. And again, if I'm able to heal and relieve pain in the worst of the worst, it stands to reason that I'm going to be able to be effective in treating lesser wounds like burns and scrapes and abrasions.
Great. Thank you, Dr. Maida. And our next question is, with your patients using cannabinoid topicals, were any other medications used or dressings used?
So, I mean, if patients were on opioids at the beginning, obviously we needed to scale them down slowly. We weren't going to stop anything immediately because people could get a rebound effect. Many of my patients, uh, of course, another way of reducing pain is by being very careful with the different contact layers that you apply to a wound. So what I've found with cannabis-based medicines or the oils is to apply a non-stick agent that's neutral. And my favorite one has been Gelinet, which is paraffin-based 2L. It's non-stick and it doesn't interact with oils or cannabis-based medicines. And then if they were heavily exuding, I might apply something like a Mesorb, which tends not to stick when applied onto the Gelinet and so on. And then most of these patients had edema and needed compression therapy. So everything was very compatible with all of the above.
Great. Thank you. Our next question is, what kind of topical cannabis products do you have?
Well, at the moment, they're not available because they need to be further developed. But in the interim, patients can still use cannabis oils from licensed producers, not from Amazon.com and not from dispensaries and not from backstreet vendors. As long as it's from licensed producers, you know, technically they can be applied to a wound, as long as the wound doesn't go down to bone or doesn't go down to any organ systems or whatever. But if it's epidermis and down to dermis, it should be completely fine. Um, Wounds are lipophilic in nature and therefore will absorb cannabinoids very readily. But also, I've also made a point of recommending it applied to the peri wound because cannabinoids and non-cannabinoids will also restore the health of the surrounding tissue. And this is something that I really feel strongly about, is we need to think beyond the wound bed preparation model where everyone's just focusing on the wound bed. If you don't restore the health of the surrounding tissue around the wound, we're not going to be able to have as much success in treating the wound itself.
Perfect. Thank you so much. And the next question is there a listing of all the cannabis clinics you mentioned across Canada?
Um, Good question. And I honestly don't have an answer to that. But I suppose if you Google, depending on which city you're in, I'm sure you'll come up with a list. But again, consumers need to be careful and make sure that the clinics are actually recommending licensed producers and not dispensaries and other illicit sources. And our sponsor is associated with a couple of high quality clinics. And um, so you can also reach out to any of the licensed producers and they may make those recommendations or references.
Great. Thank you, Dr. Maida. That is all the time that we have for questions this evening. So I would like to thank Dr. Maida for your engaging presentation, and thank you to Spectrum Therapeutics for supporting this educational webcast. Thank you everyone for attending today's webcast, Cannabis-Based Therapies, a New Paradigm for Wound Management. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's presentation. On behalf of Wounds Canada and Spectrum Therapeutics, thank you for joining us today and have a great rest of your day.